So hopefully, you know, as you're listening to others' presentations, it helps you to, I mean, share the excitement and, you know, sort of share some of the challenges as well. And I think you'll see some common themes as we run through these presentations. Thank you. Agnes, can you just check we're missing our panelists?
Chit-chat.
Well, can somebody tell them to stop chit-chatting? Well, hopefully. The microphone does carry out in the hallway, so you just told the vice president. I didn't have to because you did. And we're missing. Take one. Way to take one for the team, Joe. All right. Excellent. Yeah. So Lisa, Tara, Morgan, and Annette.
Go back down as soon as I'm done. Okay. So from my right, yes. Tara? No. Morgan, Tara, Lisa, I'm Annette. Sorry about that. So we did It's About Time, and it's kind of a reflection about it's about time we did something, but it's also about the time that folks are waiting. They're up here. So we decided to actually tell our client's story. Paul is leaving the hospital after 7 days in hospital for treatment of his depressive symptoms. He's not sure what the plans for life after hospitalization are. He's given a shopping list of people and programs that he could call and an appointment with a psychiatrist. Also included is a list of various medications that he may or may not still be taking. Paul hasn't been involved in much planning and was only told the morning of his discharge that he would be going home in a couple of hours. He's not sure if and to whom this discharge summary may have been given. He leaves the hospital confused and overwhelmed and may likely return. So what are we trying to accomplish? Our aim statement was by January 31st of 2018, 50% of adults with a diagnosis of major depression who are transitioning from inpatient psychiatry at Sioux Area Hospital to community mental health and addiction services, either within the hospital or at CMHA and vice versa, are in receipt of a clear, comprehensive transition plan that is shared with all appropriate service providers. During our journey in this test, we did expand the population to include individuals experiencing depressive symptoms so that we could increase our volume to test our theory. That's just an aside note.
Okay. So, lessons learned. Our enablers, our team remained positive and committed. Training, education, and coaching from Alice was wonderful. She was always available for every meeting and keep us on track and keep us positive. Not on our slide, but very important is we had a psychiatrist who joined our core team. He also ordered the transition plan we developed for some of his patients who met the criteria. We also had assistance and support from our nurse educator, and more recently we had a student nurse who is using the transition plan as her change project. So that's been actually excellent. Our challenges, staffing role changes, including direct service staff, which would be myself. I was the discharge planner when we started this project. I'm now taking on a different role as a community treatment order coordinator. Management, Lisa is still a manager at Sioux Area Hospital, but she's managing different teams now. And our executive sponsor has changed. We're lucky to have our executive sponsor here today. However, it's a different executive sponsor than who we started with. Layers of management and dual reporting by direct staff. We have a lot of different managers involved at the hospital for the people who are involved in the project. Competing, managing workload, data collection, manual pull, and privacy. So identifying which clients in the hospital who would meet the criteria for a plan sometimes wasn't always done if there wasn't a staff member at the team meeting at that time who could do it, and then finding out if finding that data later on. Also, there was a privacy issue with Morgan being from the LIN. We couldn't always share who the clients were with her, and also with Annette, who's from CMHA. So we had to often code the information, so just the client name and use client initials and stuff like that. And then it took us a while actually to get the transition plan right. It took us until the end of December until we were comfortable with a plan that we could start using. Changes, so we introduced a new transition plan. So that was replacing the traditional plan that we use on the inpatient unit. That was also going to be a plan that was going to be used from Canadian Mental Health for patients coming into the hospital. So this plan would be used for people who had major depressive disorder. And then, as Annette mentioned, we would be using that for people with depression symptoms later, because we realized that our population, we didn't have a large population of patients with major depression. And so that plan is one page both sides. And then we also had another sheet for the patients to use, and it's an action plan. And so we provided details instructions on when and how to use the new plan, including a mock plan. We provided emailed instructions face-to-face and a hard copy. Communication with staff, leadership, providing clarification on the plan completion, sent a memo to all psychiatrists outlining the project and requesting they consider adding this to their physician orders, which the psychiatrist on our team was doing. Identified influencers attending morning inpatient rounds and assisted in identifying appropriate patients and assigned accountability, and re-enlisted our supervisor a couple times to help us with identifying the patients who would meet the criteria for the plan.
Okay, so over the course of 10 weeks, we tracked the number of in-scope patients discharged from the inpatient mental health unit at Sioux Area Hospital and how many of those patients got a transition plan, and then we charted the percentage of that. So we saw that in week 5, 43% of our in-scope patients got a plan, and in week 10, 31% of our in-scope patients received a plan. This gave us a total of 10 plans created over 10 weeks. We also monitored how many in-scope patients had a plan shared with both outpatient mental health at Sioux Area Hospital and CMHA. While we saw that all 7 plans were actually shared with outpatient mental health and 1 with CMHA, we charted this information to show the percentage of plans shared based on the total number of in-scope patients discharged. So for example, in week 6, we saw that 20% of in-scope patients had a plan shared with outpatient mental health.
So our impact on clients from a qualitative perspective was overwhelmingly positive. All of the clients that we had, although it's a small volume, their feedback to us was very positive. They liked the plan provided. Some said they felt it was the most meaningful interaction they'd had during their inpatient stay, which came to us with a bit of mixed response, but they had a very meaningful interaction. That it was helpful to do that themselves, and similar, I think, to the Timmins group as well, where we have patients or clients actively engaging in what's going to work best for them. And then impact on end users. It did add some time constraints, as we mentioned. There were changes to both the direct service providers and scheduling, and in our test trying to trial it, we became very dependent on 1 or 2 people to get this work done, and depending on their skill and will, that became very challenging at times. I think Alice was very helpful at key times to encouraging us not to be discouraged, and really looking at the adaptive change piece. We felt like we had the technical piece figured out, and then what did we need to do, and just reminding us that that's normal. I shared that information with our leadership team as we were working on our own adaptive changes. And then they were reporting increased time to complete, which we are starting, I think, very early on to see that time start to shrink as people get more comfortable. And then the value, they did see the value increase to both the patient and the interaction with the patient. Our next steps obviously would be continue the adaptive strategies, the what's in it for me, for both patients, staff, physicians, and community partners, and looking to knowing the workload that those individuals have right now. How do we turn down the heat? And if everything feels like a priority, how do we do that? Expanding our team further to include more direct clinical staff, and engage differently with Heather, our executive sponsor, who picked this up with many other, conflicting priorities. I don't know if anyone saw the W5, the piece from Steeltown Down. That's our community, and Heather has been quite prominent in making sure that our withdrawal management proposal goes through, and so keeping you engaged and keeping our senior leadership team engaged as well. Explore the roles in the job descriptions. So as we are replacing the discharge planning position, how do we build right into that job description and that standard work, and reviewing the plan and getting it into our EMR as soon as possible. We have a meeting with our forms committee Thursday of next week to get that formally approved. So that's it. Thank you.
Thank you. How many of you have the hair on the back of your neck stand up when you hear forms committee? Comments or questions from our panel? Go ahead, Paul.
One thing that the groups I worked with too also struggle with, and when I look at the standards of struggling with, is the word comprehensive sometimes as an operational definition. I was wondering for you guys, you talked about, I think you mentioned comprehensive care plan as part of your transition. How did you guys approach that? Like to start to think about like what would fall into it, and who did you engage in that process?
So we stole from another team that had one posted in quorum. So that was very, very helpful.
It's boring, good ideas. Yeah.
And then,
It's not stealing. It's sharing.
It's
It's sharing.
we're not giving it back. But we also, with HealthLink and the coordinated care plan, we had already brought that to our patient and family advisory, and we knew what they wanted to see in that. We also worked directly with Dr. Nyogu, who's a psychiatrist on our core team. And even in that, we have a fairly comprehensive one-page plan for the healthcare provider and the action plan for the client or patient. Big piece that kept coming up with the HQO standard is the piece of current risk for suicide. Mm-hmm. And it came up time and time again with staff discomfort around assessing that. So we continue to address that.
Just to follow up, we've had at CAMH, there's been an issue where they're trying to implement more screening tools around suicide as well. And an issue that comes up for a lot of clinicians is what happens if your kind of clinical assessment differs from the tools, right? There's a bunch of risk factors, protective factors, and how do you balance that and communicate that? So I think that's a big issue, yeah. Thanks.
Go ahead, Ross.
So a lot of the challenges that you report really have to do with workflow and responsibility. And in your early stages, it's sometimes difficult to reduce the amount of work doing because you're doing parallel systems, right? You're sort of adding work. You're not sort of. What's the prospect moving forward that this is something that could get integrated into the workflow and the current systems and therefore make it easier for people to do that without competing with other responsibilities?
So I think the big piece is having it become standard work. And once we get the forms committee approval, we do have an in, that becomes the replacement document, right? So as we move forward with our HIS upgrade, it becomes, I think, a forced function as well. So
and the other
big
piece is
answers.
the feedback from the patients seems very positive. I wonder if that's something you can use as you move forward to sort of get people's engagement.
Thank you.
Go ahead.
First of all, congratulations on persevering, I think, despite all of those challenges that you mentioned. My question was just in regards to your SPC charts that you showed, and you had those 2 points in time, I think it was around week 5 and around week 10 where you saw improvements. Any idea why you had those two points in time where you had more referrals or more shared?
I do know. Yeah. So I know that, to be honest, like I was present in week 5 to identify the patients again. I had there is no discharge planner right now. That role was posted, and it's hopeful that they will be replaced soon. So right now there's 2 people taking on the load of that person, the role of that person. And so there wasn't always a person at our rounds where we identified people who would meet the criteria for that. So we were making sure, like at week 5, I know I was present, able to identify patients who would meet the criteria. In week 10, we had the nursing student who was identifying patients, and she's been there all the time now. So we'll see an improvement moving forward. So, yeah.
Any comments or questions from the group? Yes, at the back there. I don't know where your microphone. Here comes Laura.
There's just one more piece on that. Week 1 was December 21st, and week 2 would have been January 1st, right? So it did skew our data.
Yeah.
So I have a question. I think you said that you had a separate action plan for the patient as well as the part that's going to go in the EMR. Are they the same, or how are you going to implement the 2 different pieces?
Go ahead, Tara.
Okay. So the transition plan is going to be part of the medical record. It's replacing the discharge plan. The action plan is a plan for the patient to use. We're hoping that the action plans could be used for all patients. So it just has a list of contacts. It has different adjunct therapies that they could use, like participating in yoga, using light therapy, different things that they could use that would be beneficial to them.
So is it something they fill in with you, or it's just a piece of paper that you hand to them?
No, we're hoping that the staff will fill in with them. Yeah.
Okay, great. Thank you.
Excellent. Thank you, folks. Excellent. Enhancing Comprehensive Assessment for Major Depressive Disorder, Monica, Sammy, Claudia, and Maureen. And just as this group comes up, I want to share with you, we started off this morning talking about community and the amazing community you're part of with Cohort 13, but the larger community. And I just want to share with you that after the comment earlier this morning about the patient-oriented discharge summary, I had an email from somebody who's watching on livecast that gave me a list of hospitals that are actually piloting it right now in case I want to share it with the team that talked about that. So that's the amazing community that you're already a part of. While you're up here sharing your successes, we're getting information, people trying to help link you to other projects and other initiatives that are going on. So I just wanted to share that because that will continue to happen to you now that you're part of this large QI community. Very good. Thank you. Excellent. All right, go ahead, folks.
So hi everyone, my name is Sammy Barakat. I'm a staff psychiatrist at Halton Healthcare Services, which is Oakville, Trafalgar Memorial Hospital, Milton District Hospital, and Georgetown Hospital. These are my colleagues, Claudia Barning, the patient care manager for outpatient services, Maureen McDermott, our professional practice clinician lead, and Monica Bettazzoni, who is the director for our overall mental health program. We are going to talk about enhancing comprehensive assessment in a one-time consultation format for major depressive disorder. As you can see here, we dated our, we believe in the power of positive thinking, and although it's March 2nd, we dated ours April 2nd because we want spring to come sooner. So I tried doing this in my clinical practice, but apparently the college won't let me date July 1st for January assessments or something. So, our project AIM. So we're hoping that by this coming September that 90% of patients who come to the consultation clinic will receive a comprehensive assessment. And by that we mean a clear, and include a comprehensive assessment, clear explanation of their diagnosis as well as information on recommended self-help strategies and community resources in the form of a handout that they can take with them. And our hypothesis is that the psychiatrists that work in our clinic already provide a lot of this information, but it's not in any kind of standardized format. And we have a further hypothesis that although patients indicate, yes, I got my diagnosis and I was made aware of some community resources, if you were to ask them a few weeks later to list those resources, they probably will have forgotten many of the names that we talked about. So, just a clinical vignette to give you a sense of things. A 48-year-old man with symptoms of depression referred by his family physician to our consultation clinic for assessment, diagnosis, and treatment. Presented with low mood, saying this started 2 years ago after the death of his father. It's getting worse. Was diagnosed by one of our psychiatrists with a major depressive disorder, verbally given recommendations for treatment and community supports. Completed an evaluation survey of his appointment and reported that he understood his diagnosis and was very satisfied with the care provided, but then called back 3 weeks later saying he couldn't remember the recommendations and wanted more information about his diagnosis. So, phase one of our project was to assess the current state of patient satisfaction. So we developed kind of a pre-questionnaire that we handed out to patients in our consultation clinic, then create an information package that can be emphasized, that we wanted this to be explained by the psychiatrist, not just handed out, but kind of certain points in it verbally emphasized and given to each patient with major depression. And now we're just about, this coming Monday, moving into a trial period where the package is being handed out, having been kind of vetted by members of our department, our Consumer Advisory Committee. It's an iterative process that will change over time. And then we'll move on to assessing the outcomes and ensure this is meeting both the patient needs and the standard of care. So what are the challenges? Time. So we're heading into accreditation in the spring. We have multiple projects on the go. We have a large amount of expansion going on in our region. So just like everyone in this room, finding the time is always a challenge. We also happen to be extremely under-resourced in terms of psychiatrists at this present time. So our current outpatient group is spread over a number of different clinics, of which only one is the consultation clinic. In terms of supports, our psychiatrists are a good group. They're motivated for quality improvement. We had a needs assessment kind of meeting with them. I spent an hour with them. They all attended. It wasn't just the pizza. They all wanted to be there. And we had kind of good ideas put about what should be in this form, what's necessary, how we can develop a more standardized kind of assessment process. We have a good leadership group. Our team members are motivated. What did we learn? That quality improvement takes time. That apparently one PDSA cycle is not enough, and that just leads to more and more and more PDSA cycles. Every problem's an opportunity. That's very optimistic, Maureen, thank you. We don't have to get it right the first time. You don't need a large sample size to show evidence of something. And don't overlook anyone needed to participate in a change process. So kind of cast a wide net in terms of stakeholders of which this could be applicable to. So we had a small, kind of a slow start over a period of around 11 weeks. Only 8 of our pre-surveys, we had around 8 returned. That's for a variety of reasons in terms of number of consultations being done, psychiatrists being spread out, getting patients to return surveys. But that number kind of has been steadily climbing. Interestingly, our initial hypothesis was true. Again, we have a good group that do good assessments, and if you look at the documentation, you can kind of see that a lot of things have been implemented. So the satisfaction surveys of those patients pre any intervention are actually pretty high, but again, the hypothesis is that's coming right out of the room and that things would likely change a month later. So what are our next steps? So we're going to trial the patient information handouts. So these are handouts that include a number of different things. They include information about major depressive disorder, what it is, how it differs from regular sadness or bereavement, what are the signs and symptoms you would look for. It moves on into evidence-based treatments like psychotherapy. There's a mention of cognitive behavioral therapy, interpersonal therapy. There's an entire section that's been kind of well put together with colors and shading related to complementary and alternative treatments like yoga, like exercise, like light therapy. And finally, a list of our localized region-specific community resources, government-funded community resources in terms of counseling services, CMHA, information about our centralized intake, one link for mental health and addictions in our region. And finally, some popular apps and websites that we put together that we can give patients to explore on their own. So we'll continue the evaluation of the patient experience to track their satisfaction. So starting this coming Monday, psychiatrists are going to begin verbally explaining the forms and handing them out, and then using the same satisfaction surveys to see if there's a shift or a change. Improve patient information handouts based on the feedback, and we're hoping that eventually this can be used in other clinics, on our inpatient unit, and other services within the mental health program. And we're going to continue and in terms of lessons learned, QI process, patient survey, and handouts are going to be applied to other clinics and diagnostic categories as we kind of become more familiar with the other HQO standards.
Thank you. Comments, curiosities from the panel?
Just one a great project. I'm wondering if there's an opportunity as this gets further implemented and you get further down the road in testing this, to look at whether you see a decrease in clients calling back saying they're unsure, just that down the river effect. Also, folks may be connecting with their local CMHAs or other providers to see if once they're provided the information, are they following through with it and ending up at the door of the correct place.
Right. I mean, we're obviously in a situation where, as a result of resources, we offer, a lot of one-time consultations. We do offer follow-up as well, but the hope is that a tool like this might preclude the need for re-referral by family physicians or self-re-referral, and guide patients to resources that they may not have been available. But yeah, that would be a definite follow-up to manage to see whether it's actually making on-the-ground difference to their improvements.
So it's always challenging to get people to fill out surveys and return them. What have you learned about the best ways to do that?
Big red envelopes that are shiny. It's one of those things where, again, it was a pre-survey, and again, due to the timelines of the program, I think we just kind of kept it moving. Yeah. And whatever surveys we got, I think there are different strategies.
I think it's having the bright envelope as a reminder. Sorry, I was just saying, I think it's about having, some of the strategies that we've used is having that sort of big, bright envelope as a reminder to the physicians who are giving these surveys out. We've also talked about, how wonderful would it be if we could give out TIM cards to those individuals as an incentive for completing the surveys. We've also even talked about, we might have somebody in our waiting room giving out the survey as somebody exits their session. So we're looking at those opportunities. We're looking at, is there an opportunity to have a volunteer? Is there an opportunity to have a peer mentor sort of, be part of this process?
I think a significant challenge was that because we're gearing it towards major depressive disorder, only the physician and the patient know that they've been diagnosed or confirmed a diagnosis. So if you have someone in the waiting room, if it's going out to all patients seen in the consultation clinic, that makes sense. But how do you, without breaking confidentiality, gear it towards patients? Oh, that patient just came out of so-and-so's office. They have MDD, So that's something that was a challenge.
One of the things you brought up was there's kind of a shortage of psychiatrists at the time, and it's kind of more of a consult-based practice. And so one of my practices where I don't have that many people lined up, I have the luxury of time of sometimes going through, this is what my formulation is, this is what I think you've shared with me, here's some ideas I'm going to pass on to your family doctor. But if it's a different type of clinic, I don't have that time per se, especially when you have like a load of people waiting to be seen. And I wonder if there are different ways we thought about how to, you talk about the tool being really helpful, especially when someone explains it. And I wonder if there are other ways of kind of using other resources you have in the clinic to still be able to do that, but then still allow your psychiatrist to do, I guess what you need them to do is to do the consult and get the recommendations.
So some of the things that we've talked about is, using our website to load the information on. The other thing is that this particular clinic has a bit of an RN attached to it. So we've talked about, does it make sense is there a post visit that everyone with MDD can sit with the nurse and have a little information session? So it's definitely something we're struggling with, and what's the most effective way of delivering that information. So definitely something we're trying to explore.
Thank you.
Any other comments or questions from the group?
We have our handout here as well, if anybody wanted to come by and look at it at any point in time.
And I think it's on Quorum too, I believe, right?
The handout is not.
Oh, okay.
But we can load it later.
Excellent. Some of your other tools are there as well. So excellent. Yeah, thank you for bringing that. Excellent. So as these folks receive their certificates and get their photos done, we'll ask improving referrals from primary care to psychotherapy. Kevin, Rebecca, Pierre, Mark, and Genevieve.
So as the crowd comes up here, I'll introduce them. This is Dr. Pierre Ferguson from Hawkesbury General Hospital, Rebecca Fromowitz from Jewish Family Services Ottawa, Genevieve Arturi from Hawkesbury General Hospital, and Mark McCauley from Family Services Ottawa. And our goal was to improve referrals from primary care to psychotherapy. Our issue really was we didn't think the physicians seemed to know how our psychotherapy services can help their patients. Clients who are sent to the services didn't seem to know what to expect and are not as prepared as they could be to benefit from psychotherapy. So we agreed that we needed an informed referral pathway. Everybody would know what to expect, and everybody's really more ready to commit to the process. So we focused on our project to create a clear and simple information sheet and a clear and simple referral forms, and are testing them with the physicians and clients today. So our system level aim was really clients 18 plus screening positive for mild to moderate depression would be offered a first psychotherapy appointment within 4 weeks. And then Alice battled this down to a much more practical and realistic project aim so that by February 28th we would have 100% of our selected primary care practitioners referring their clients to psychotherapy by using the common referral form. And what we're focusing on in the long run are what's the client's feedback indicating that the information sheet had an impact on their decision to psychotherapy, and the physician's feedback on indicating that the information sheet and the direct referral form are effective, easy, and sustainable. We're not there yet, but we're going to continue on and hopefully see actual evidence in those particular cases. So as we see, we've got Mark and Pierre modeling the referral form. First sheet is basic information, and the second sheet is the PHQ-9. And I think even just coming to some consensus about what's the important information that has to use, you recognize we've got multiple different agencies here, hospital and community, all with their own processes, but we came to a pretty clear consensus. And I think even particularly on the PHQ-9, and I think of the depression guidelines themselves, they prescribe that an assessment be used, but they don't prescribe which assessment. But if you look at the presentations today, it seems like we're pretty much landing on the PHQ-9, and at some point I think, at least in Champlain, we'll be saying that's our assessment for this particular circumstance. Our theory was really that clear and simple information in support of the referral decision and the referral action will aid the client in choosing psychotherapy. We were quite amazed at the times clients would show up and say, well, I'm not really sure why I'm here. My doctor told me to come and I don't really know what psychotherapy is. And so we really wanted to make that as clear and simple, because how can you commit to a process like psychotherapy unless you understand how it could help you? And we think that if you have informational clarity and simplicity, that'll increase the assistance in choosing psychotherapy. And we really thought, we were actually most worried about the number of referrals that would be coming in. We hear from primary care practitioners all the time, the thing that keeps them up at night are clients that present with mental health problems. They don't know how to help them, and it really keeps them worrying. And we know as a percentage of presentations it's very high, and we know in the general population 1 in 5. So we were really frightened, but in fact it's not happening. They're trickling in. We think there's going to be a curve. Maybe it's like he'll tell 2 friends and she'll tell 2 friends, and before you know it, it'll be exponential. But we really haven't seen the numbers yet, but we're still very hopeful, and we recognize this is an ongoing process. This wasn't a 12-week project for us. Some of the things that we've been doing as next steps and through this process, we recognized we needed to respond to this issue of referrals. We needed to increase the reminders to clinicians to address the challenge of change. This isn't something we could do once. You really got to develop those relationships with the primary care practitioners. I think we started out with primary care practitioners we already felt would be sort of ready for this, but you still got to remind and hound maybe a little. But you got to create those reasons for them to take the little bit of extra effort to help out and to follow a new bit of a process. We actually switched up an alternate location for clients who may live closer to an alternate site. We recognize that even just the bus trip to get to that office that's a couple of extra miles away was enough of a barrier for a client to not seek service. So we said, well then, Why don't you, that was in the case of Jewish Family Services, well, why don't you go to Family Services Ottawa? It's a little closer to your home, and that, I think that kind of adaptation was important. And we're talking about agencies here that provide services on in some cases on a sliding scale basis. An agency like Jewish Family Services and Family Services Ottawa, they do provide services directly funded by the LHIN for very particular needs, but their broader service is around counseling, and it's funded by sliding scale. But in this case, the organization said, well, we'll just drop that altogether for now. To note that the sliding scale was, at the low end for a person with a low income was very, very low. But just to make it more of a clear statement, say, listen, forget about the sliding scale for cases who are coming through this process. We had to adopt a proactive communication approach. We're developing a poster, which Rebecca will model here. This is the one that Jewish Family Services created, and Genevieve has the one from Hawkesbury General Hospital. We're talking about, well, what's it take to actually get a poster on the wall? These pharmaceutical companies are really smart, eh? They get stuff on the wall all the time. They show up the doc, and so we've got to start to adapt or adopt some of these kind of basic marketing approaches if we really want to engage a diverse group like primary care practitioners. And we recognize this is an ongoing process. You can't just tell people something once and expect it to change the world. But we also abandoned at least one thing. We had a particular criteria we were focusing on that we really just wanted to focus on those new recent onsets. We said, let's drop it. It's too much of a question for the primary care practitioner to sort out. Is this a recent one, or is this something I heard about before? Or is it recurring at some point? So, well, just don't worry about it. We'll forget about that criteria. And still, referrals are only trickling in. We've got a few in. We really thought that maybe there would be 2 zeros after this number. That's what we feared. We had hoped there'd be 1 0 after this number, but we've got a few referrals trickling in every week. I won't talk about, I was told I shouldn't talk about trend lines. I think there's a trend line here. I think it's going up, but not supposed to talk about that. And we specifically want to know how many of those are coming in using our common referral form, because there's still a process in the background going on where they're coming in, and quite a few. Like, our goal was 100%, and for the vast majority, when you compare the blue line of number of referrals to the number of referrals using a common referral form in red, almost all of them are coming in. And again, I think there's a trend line. I think it's going up. But we also took a look at which doctors in particular were delivering on this, and it seems there might be some early adopters. Dr. Langell seemed to have brought in a number of patients, and I don't think it's solely because of his volume of patients. But it gives us an idea, and this is something I think we would track going forward. But our interesting ones, which we can't really show you any data on because these are people who are just getting introduced to care, how much of an impact was this clear and simple information on the client's decision to seek care, and how easy and clear and simple was for the physician to facilitate that care through our referral form. So I think what we're most excited about is that we've learned, I think, to be a little adaptive in our approach. When you have multiple agencies, multiple sites, multiple partners, you got to be flexible about how you do this. And that's, I think, the underlying skill that we're really learning through this quality improvement project. But we also recognize the significant challenge of change. There's diversity of practice and process that's part of connecting primary care practitioners to organizational service programs. But if we want to do this right, it's got to be built on a robust foundation of primary care involvement. And we have heard back from clients. In this example, would not have thought of counseling if not offered by my physician. I thought there was nothing that could be done about my situation. It's a relief that this counselor gets me, and in my case, it really helps to have her on my side. There are challenges of change. Sometimes do no harm translates into make no change. Agreeing to a change and habituating a change are two totally different things. And I think all providers want to make improvements for clients, but sustained change really requires improvements for providers as well. Somebody was talking somewhat facetiously about a quadruple aim, which includes the benefits to providers. I think in the background, I'm not willing to say quadruple aim yet, but in the background, we really need to keep that in mind if we want to sustain change.
Excellent, thank you. And Kevin, Laura, and Jacob will see you afterwards for a trend line discussion.
I know. I shouldn't have mentioned it, I'm sorry.
I knew he was going to go there. Comments or questions from the panel? Ask Kevin what a trend line is. Go ahead.
Yeah, trend line. Okay. So when you talk to family physicians, what do they tell you about the challenges about making these referrals and increasing the number of? Do they agree that there are people who are kind of getting under the radar, or do they have a different view?
Rebecca, do you want to try that one?
Sure.
Come on up to the mic.
Oh, yeah. Unfortunately. I think that primarily the issue had to do with, we were linked up to Somerset West Community Health Centre, and I think that for a lot of the patients there, they wanted to stay within the community health centre, and so I think that became very clear is they were not really willing to go the distance, but they were also not willing to move outside of their community. They wanted care there. I think that we also didn't have enough time, and doctors may have required more time with their patients to see them a few visits to be able to make that referral. I think those were the primary things that were identified to me.
Yeah, I think that's really important. We have this hope that one-time contact, emerging mental health problem, let's get you connected to care. But we all know that some folks spend a decade struggling with this before that's even really identified and connected to care. So it's not surprising it might take more than one appointment.
If I can add one thing, the other part that we've heard from some physicians is when you start putting limitations around the PHQ-9 score, then they feel like they're limited in their discussions with clients because, if they don't fit in this range, then I'm wasting my time referring them. So it's something for us to think about when we put limits and scores around things.
Any other comments, questions from the panel?
Ross kind of stole my question. But it's interesting you put up because I think a common theme, and especially these standards, are the PHQ-9, and how do we use them and implement them in a meaningful way, but also recognize their limitations. And I think that's an interesting thing that you stated, that sometimes people felt, well, this patient on paper on this evidence-based tool might not look severe enough for referral, but and some of the groups I interviewed or not worked with, they also said that sometimes there'd be a discrepancy between the physician saying, well, like, you're not able to work right now, you're taking sick leave, but your PHQ-9 doesn't show that you're like moderate or severe, or vice versa. And how to deal with that discrepancy or communicate it, I think it's an actual challenge, like especially in mental health, which it's not so clear cut. There's not like vital signs or other things that is more objective.
And yet you're working with primary care practitioners who have those kinds of expectations on other test scores, and other prescriptions, and other referral processes where it's kind of black and white, and then you've got this kind of soft thing going on this case, yeah. Mm-hmm.
Comments, curiosity from the group? Yep. Oh. Jenna.
I had a question about if there's been any talks about implementing a feedback system to the primary care providers. I've done some work with primary care, and that seems to be a theme that emerges, that even if they make a referral, they don't really know what happens with it. Yeah. Just a question on that.
Genevieve, you want to try this?
Yes, we've had that talk. We actually, at the Hawkesbury program, already had that kind of feedback loop where we have a form that our intake service fills out after intake and explains which program the client is going into and the expected wait time, if any. So we've shared this form, or will be sharing. We had that discussion with our Ottawa colleagues so that they can have that sort of a written standard feedback. Yeah.
It also, just so I could add to that, it also reflects the difference between sort of that closed system and open system. So in Hawkesbury, you've got one hospital, which is also the lead for community mental health and addiction services, and one very robust primary care family health team. A couple of others as well, but so it's kind of easier to build a system of feedback loops in, and it's much more diverse in the Ottawa area.
Excellent. Thank you, folks. Thank you. And I think the posters are up on Quorum, and Rebecca has added poster making to her resume, so I'm sure she'd be glad to tell you. I think it's safe to say it was easier than she thought it was going to be. I think it's fair to say that, so she'll be glad to share her tips with you.
We've got copies that go from here as well.
Oh, excellent. And copies here. Oh, this is excellent. We get take-home swag as well. Improving depression care at the Clinton Family Health Team. Erin, Agnes, Pam, and Julie.
Nice. It should be more like smoke machine lasers.
Good morning. So you will all see we are not superheroes today. When we started the project, we thought we will have lots of patients, lots of time, and lots of data. That did not happen. After October, we had our session in Toronto. We realized we had to come down from 20 PDSAs to maybe 2 or 3 and make it realistically. And we changed our outfits, we changed our attitude, we adapt. And we went back on our horses and continue our journey for Ideas Project.
So to start, we wanted to highlight what we feel is a success. There was a young man who was referred to me for depression by his mother, but he really was not interested in treatment. And even though that there were different people in his care team that were motivating him and encouraging him for treatment, he was not interested. And one of the things that happened is that we gave him one of our interventions, which is a toolkit about depression care. And it actually, the discussion that came out of that encouraged him to try light therapy. And so that was a really nice piece that we highlighted throughout our time to say, look, patients are more engaged because of the work that we're doing.
So lessons learned, our focus on quality improvement increases our accountability. It allowed us to have some standardization in terms of the management of our patients, ensuring that they were getting timely access to care, and that they were actually going to be showing some improvement with the care they were receiving, and that nobody was going to be falling through the cracks. It promoted us getting out of our silos and working together as a team. I know prior to this, my engagement with the mental health team was fairly limited, so it's been really a benefit to get to know them and to be able to work together towards improving patient care. Real world change is complicated, even in terms of initial data collection and being able to do searches. Credit to Kim, our sponsor, for doing this, to get some baseline data, because patients aren't always coded necessarily the same way by every provider. In terms of collecting our data, it's a lot slower than what we assumed it was going to be, and that's true even in establishing the interventions and the tools that we wanted to do as well. And also, we're a small practice, so we don't necessarily have the numbers either, but so our aim was to provide a standardized information package or toolkit, and we were able to do this. We wanted to be able to track patients' goals, and so that we could actually tailor treatment towards the patients, and I'm going to speak more to this in just a couple seconds. And we also wanted to encourage patient improvement and demonstrate improvement in a shorter period of time, so within a 2-month time frame. Our ultimate outcome was to make sure that all our patients had PHQ-9s done, and that we wanted to see a 5-point decrease in their score by the 2-month mark. In terms of process measures, we wanted to ensure that 80% of the patients had a Sheehan disability scale, which that was new. We also wanted to make sure that they got the depression toolkit at diagnosis, and that there was a depression flow sheet created on the EMR that would have everybody use it in terms of who cared for the patients. Changes, we obviously created the toolkit. This would also give the patients something to start working on while they were waiting time for meeting with mental health workers and or with medications. If they were started on those two, we give them an adjunct for that. We also had separate handouts that we would give them to once they've had a chance to look at the toolkit and established maybe some things that they wanted to try, for example, light therapy. We introduced a scale of functioning, the Sheehan, which we never used before, not just the PHQ-9, which we were using. And we provided a new flow sheet on the EMR that everybody could use, and it auto-populates from previous visits. And then we also have an action plan that we haven't actually started using yet. Sorry, it's here. But it will have the patient's goals so that we can then establish that that's being met as well.
Now for some results. First, we wanted to just make sure that patients were getting the intervention. So our goal was 80%, and for the most part, we met that in terms of getting the PHQ, the disability scale, having patients or review the information. And one of the things we wanted to know is what adjunct therapies or self-management therapies were people engaged most with. And they were interested in exercise, followed by sleep hygiene and nutrition. Interestingly, outdoor activity, no hits, could have been winter related. So we're interested to see going forward if that may change. We really want to look at baseline scores over a 2-month period of time, how much change in the PHQ-9. Our goal was 5-point increase in this period. Green line, everything to the right of the green line, right? Yes, everything to the right of the green line indicates after the intervention, 6.2 was the average improvement. So we met our goal. We don't have a lot of data points, but the trend, or it's promising anyway, that it's I'll take trend away, but it is promising that we're on the right track, that there was an improvement. However, when we asked patients what they thought about the intervention that they received that was new to this project, about this toolkit, they actually reported not all that helpful, already knew this information, didn't care much about the patient or the nurse practitioners reviewing the information. So we were a bit confused by that. However, great feedback in terms of did they feel involved in their care and supported in their care during a diagnosis and treatment of depression. So there's some information in there that we need to figure out. We suspect that potentially patients didn't quite understand what we were asking about with what the toolkit, because the information itself was not the only intervention. It was the follow-up, the action plan, and such. So more to come with that.
So the impact, the focus of this whole IDEAS project on depression was that it led to examine our triage process. And because of really examine that triage process and contacting all the patients in the first 2 weeks after their diagnosis, it resulted in a smaller wait list. And even so small that we do not have a wait list anymore. So we are really, really happy with that. There are more appropriate referrals. So people that have benefits themselves, they are being referred into the community instead of receiving social work services within our clinic. And that opened the wait time significantly. And patients have an increased knowledge when starting the therapy. All in all, we saw that the patient's experience and the care is improving. We have interactions with them within the first 2 weeks, and we will always, also intend to contact them after 2 months to see what interventions they chose, because the people that go outside the clinic and receive treatment, they are now being followed up, and in previous years, nobody knew if they would follow up on light therapy or counseling. They were out of the picture. So that's really good. The next steps to improve is rolling it out to all the other physicians. Everyone will get the depression toolkit, and we will have on every chart on the EMR a flow sheet, and that flow sheet will come down, so we don't need to scroll up when was the counseling, when was this being done. Everything is right away at that appointment, so it will all fit in. And we like to expand to anxiety.
And promising is a good data word. That's okay. Promising is a good word. Yeah, promising. Comments, curiosity, Michael?
Fantastic project. Thank you. I'm really interested in the, and if I'm understanding it correctly, there was an improvement related to, or possible improvement related to the PHQ-9 scores, and then your client's feedback is that the toolkit didn't feel super helpful, but they're still feeling more supported. So I'm just curious if that's something you want to flesh out further. Is the intervention that's making that improvement possibly not the toolkit itself, but maybe it's the relationship or the conversations or that support that's going along with talking about the toolkit? That's pretty interesting.
Yeah. I totally agree, and I hope that when we get in contact with the patients after 2 months, that will give us more data to answer those questions too.
Just to follow up with Michael, I think it's really interesting because sometimes when we think of information brochures or toolkits, like a lot of hospitals do that, sometimes the assumption is that it's a knowledge gap, that if people knew about the resources available, then they would utilize it. And almost I wonder from your part, I can't assume, but maybe when you talk to them, it might be more, I know about them, but it sounds like I want support in actually doing it, or I want coaching or motivating, right? Because let's imagine if you have depression, motivation might be an issue. And so it's not like, well, I know exercise is good for me, but I need someone to keep me on my goals. And that'd be really interesting kind of following up how you might tweak it or...
Yeah. And that was exactly the feedback that patients were giving us is, none of this information was new, but then we had them do a SMART goal. And then the idea is that they follow up with our mental health services. Okay, I see your SMART goal that you set with the nurse practitioner was exercise, but it was very specific. Let's talk about that. And so that, I think, was the support and the included in the decision that we were seeing. But the toolkit themselves, they said, this is no additional knowledge.
I see. So people kind of use it as a tool to kind of pick something where you can do some behavioral activation or work on it.
Yes,
it's interesting.
exactly. And if I can make an addition, on the flow sheet on the EMR, the goals are being reported there too. So every professional they see, they link back to that goal. So I think there is some
the link is too.
Link there too, yeah.
Ross, and then we have a question from the participants.
Just more a comment than anything else. And I want to sort of congratulate you on the way you've sort of presented this understanding, because people say PDSA, the hardest part of PDSA is the S part, right? And so when you ask these questions about the toolkit, you actually discover more about the context and the follow-on in the use of the toolkit, which helps you to think now about the way in which you're engaging with these patients about what their therapy is going to be and what choices they're going to have moving forward. That's really critical here, right? So the issue started out as something very simple. what's in the toolkit, but ended up in a more of a broader context of understanding how do we use this, how do we have a conversation, how do we learn what is really going to be helpful for the patient. So, that's something very tangible. I think that you should be proud of. The other piece on this is I wonder, going back to the toolkit. Did the patient suggest anything that's not there that they'd like, or was it more about the way in which the interaction happened around the toolkit?
When I asked for feedback from patients regarding the content, nothing. Changes.
Yeah.
It was just that it was information that was already known.
So it's about how it was used and what the dialogue is between the patient and the physician or other staff. Yeah.
I think that's a critique for a lot of chronic disease model things. You can think of diabetes or other issues where they're in the system for a while. They probably know about the different interventions or what they should be doing from different healthcare providers, but sometimes the support and coaching along the way, that could be really helpful.
I think we have a comment at the back. Thank you.
I'll keep it simple because it was already mentioned. I just wonder if the way that the question was posed on that regards of that question that the patients didn't find it that useful, if the question was something like, did review this with a nurse help you to take action? Maybe it would be, they would have said yes. Right.
Excellent. Thank you, folks. Bonus points for a costume. Make sure we get the cowboy boots in the picture. Managing major depressive disorder through self-management and interdisciplinary monitoring at the Ingersoll Nurse Practitioner Clinic, Sue, Christy, and Rhonda. No cowboy boots? Just try hard. Just told you
Good morning, everyone. My name is Sue Tobin, and with me here is Rhonda Heft and Christy Kent. Our project, focusing on self-management and interdisciplinary monitoring for MDD, was also supported by Nancy Bradley, nurse practitioner, and Chris Hartman, pharmacist. Our problem statement is that major depression disorder is a health issue commonly seen in primary health care practice that affects approximately 10% of our patients. Although our providers and patients were knowledgeable about the use of antidepressants and counseling for managing MDD, we identified a lack of understanding about managing MDD with adjunct therapies. We were also aware that adequate monitoring of our response to and adherence to antidepressants was not consistent. Therefore, our hopeful vision was to offer our patients a menu of options to treat and self-manage their depression and to provide adequate follow-up in order to evaluate response to treatment and improve treatment adherence. We therefore identified quality statement number 5 and 6 as our primary drivers for our project.
We feel that we have a patient story that grounds the work that we organized for our project, and we would like to share it with you. We do have actually a statement from, we're going to call her Catherine, and she shared this with us right before we left, so we don't have a slide, but I would like to just share a bit of it with you. I just wanted the pain and the hurt to stop. I couldn't breathe. I felt like I was suffocating. That was me back in November 2017, worn out and stressed out. I had always been a confident and independent person, and I was now finding myself at such a vulnerable state. During the past 5 years, Catherine presented many times with symptoms associated with IBS, as well as numerous physical complaints. Catherine preferred to avoid medication and was also receiving care from the naturopath, with whom she purchased a number of products, hoping that it would improve her IBS symptoms. Catherine's mental health history included a remote history of major depressive episode and queried generalized anxiety disorder. In November 2017, Catherine presented to the clinic in a crisis. She stated that she was being harassed at work and could no longer cope. At that time, her PHQ score was 24, indicating severe major depressive episode, and her GAD score was 21, suggesting severe anxiety. Her ability to manage her ADLs was significantly impaired. She was written off work for 1 month. Catherine was referred to counseling and was seen within 2 days. During the counseling session, Catherine demonstrated limited belief that she was capable of improving her situation. She had expressed feeling stuck, a lack of hope, and demonstrated a victimized perspective. Catherine also shared at that time that the father of her oldest child, who was conceived as a result of a sexual assault when she was 15 years old, had reappeared in her life. After 3 counseling sessions, Catherine demonstrated very little improvement in her PHQ-9 score and her GAD score. Despite Catherine's reluctance to take medication, she agreed to take an antidepressant, recognizing the lack of improvement in her mood, feelings of hopelessness, a lack of motivation, no appetite, and inability to sleep. She continued to see the counselor weekly. After 2 weeks of antidepressant treatment, the nurse practitioner assessed Catherine's response to medication using the pharmacy assessment tool that was developed by our partnering pharmacist. The PAT indicated how Catherine recognized the medication was allowing her to sleep better, made her feel less anxious, and improved her ability to problem solve. However, the PAT also helped the NP identified that nausea was a side effect Catherine had difficulty tolerating and was fearful the medication would cause a IBS flare. Catherine agreed to continue with the medication for another 2 weeks. At that time, the counselor introduced the MDD self-management plan and provided information on adjunct therapies for MDD.
Our team consulted experts and current best practices across similar populations to gather evidence-based principles and strategies to develop our tools. Research on self-management provided us with a strong perception of the value of such a tool, and it also was in line with the philosophy of the Southwest Lynn self-management program that's provided at our clinic. The adjunct sheets enhanced and improved care and communication with patients and allowed for partnership and shared leadership during the transition point in this patient's care.
Catherine began to implement her MDD self-management care plan by practicing daily yoga. Catherine ultimately decided to stop the antidepressant therapy after 4 weeks. After 6 weeks of daily yoga, Catherine's PHQ-9 score had dropped to 11. She expressed having increased energy and improvement in her mood and felt empowered. With the help of a counselor, Catherine was able to choose a career path that mirrored her belief in the natural health remedies and develop boundaries in managing contact with her previous assailant. The patient continues to make gains towards her recovery, is less focused on physical health complaints, and demonstrates a positive attitude towards the future. Catherine had shared with us that it was such a relief to be able to talk to someone and not feel judged or criticized, and someone who understood my feelings. The counselor encouraged self-care also through alternative treatments such as yoga, nutrition, and meditation. With ongoing treatment with my nurse practitioner and my counselor, I've been able to start identifying the underlying causes of my anxiety and depression. I'm starting to feel much stronger, and I'm able to cope better. I also start to feel more confident in moving forward and making necessary changes.
Catherine's story highlights the importance and strengths of interprofessional teamwork and collaboration. In order to provide adequate monitoring and encourage patient choice in treatment modalities, we were able to do this through providing the adjunct therapies through both the social worker and the nurse practitioner. Our overall aim was to improve our patients' response to treatment for major depression disorder, and the project aim was between November 1st and February 1st, our patients seeking support for major depression would demonstrate an improvement or a decrease in their PHQ-9 score. The PHQ-9 grounded our work from a qualitative perspective and provided a shared metric to be used by the nurse practitioners, the counselors, and the pharmacist. One of the change ideas we tested was timing of when the self-management care plan and adjunct therapies were introduced. We learned that timing was not a factor. Most patients were not interested in starting a care plan, but were interested in learning about adjunct therapies.
Our data showed that patients had an appetite for the adjunct therapies, but were not necessarily motivated to complete the formalized care plan.
Another change idea tested was monitoring response to treatment. With regard to administration of the PAT, it didn't seem to matter who was calling, the pharmacist or the NP. The phone is not a method of communication that is successful in communicating with patients about major depression disorder.
Okay, so with this chart, this is our control group, and the data was arranged to graphically show the change in PHQ-9 scores between the first and third appointments across our control. When we stratified the group to look at changes between each appointment, the data showed very minimal variability. A sample group was taken from patient data with criteria that all patients had followed up with their NP within 8 weeks and had at least 3 PHQ-9 scores for comparison. Due to our low numbers, we ran into some difficulties with subgrouping and sample sizes and felt that adding data would have led to a lot of interpretation. Our low numbers but continuous data also made it difficult to analyze our numbers through the use of S-bar and control charts. Therefore, we've applied the run chart due to the numbers less than 12. Also, the numbers made it difficult to create a chart that highlighted the change ideas, as many of the patients that fit our criteria for our PDSA did not have prior PHQ-9 scores. This impact chart shows that although patients were introduced to self-management, only 53% actively participated. Therefore, we needed to remove the other 40%. And the data showed that approximately half of the patients engaged with the change. When all of the extraneous were removed, our qualifying patients showed an average reduction in our PHQ-9 scores of 4%. This chart has a lot of data on it, but more for the discussion with regards to, we could have spent days and hours collecting all of the data when we looked at indicators that were identified as measurable. A significant outcome of analyzing our processes was the development of a stronger community of practice within our clinic, and the feedback was supported for both technical and adaptive changes.
Excellent. It's okay.
Thank you.
That's all right. We love the data, and we can read your next steps. So tell us a little bit. I'll ask the first question. Tell us a little bit about what's next.
Thank you for asking. So our project turned out to be a really good way of getting staff engaged in quality improvement, and also implementing the MDD standard had been built into our annual QUIP plan anyways last year. And so, as well as one of the other teams mentioned from Clinton, we're hoping to do generalized anxiety disorder when that standard comes out as well. We've also submitted a proposal for a kinesiologist who can do yoga and help our patients with chronic disease exercise and do some yoga. We have a gym that isn't currently staffed. And the entire staff got really interested in ideas. They really like our communication board, and we're hoping to do some widespread training throughout the entire clinic.
Excellent. Thank you. Christy, do you live near Ingersoll? Could you do yoga for them? No? Comments or questions from the panel?
I'll go. You talked about patients actually giving you feedback about not wanting to complete the care plan versus wanting to do more of, talk about like the adjunctive interventions. And did you get kind of their thoughts about why one way or the other, or what their hopes were in talking about one versus the other? So,
well, we had a few theories about it, but basically we wondered if it wasn't just a symptom of MDD, like just having to do the work of the care plan and not really having a high level of self-efficacy around being able to reach the goals. So that was one theory that we had. And I think too, some of the adjunct therapies were fairly easy for them to do. They could take the handout and look at it, and they didn't have to make a decision right then, and could decide later if they wanted to engage in one of those therapies.
Is one of your, I don't know, future steps kind of going back and getting a sense about, is there a way of making the care plan easier if there is difficulties feeling like look overwhelming, or what aspects of it could meet the needs like you talked about?
Yeah, I think it's a great idea to do that.
Yeah. Thanks.
Go ahead, Ross.
Just a reflection, because there's an interesting observation that the last team made about, it was the use of the tool, not the tool itself. And I'm just wondering whether you learned anything about the activity sheets that you're handing out in doing this, about simplifying or modifying them in a way that might make them more helpful.
The activity or adjunct sheets were very well received, and although we only had 16 people that participated in the actual self-management plan, we actually distributed 29 sheets of the adjunct. So I think people were very much interested in the kind of little snippets of information and the encouragement to follow up for more versus the entirety of agreeing and confirming a plan.
Yeah.
This question's a little bit off in the weeds, but I was just thinking back to the previous presentations as well, looking at the adjunct therapies and clients identifying some as being ones they wanted much more than others. And you kind of see these patterns emerge between both the teams. And I'm just curious if there's an opportunity ever to kind of flesh out why that may be. Is it a matter of availability, or is it a matter of what folks are used to? I'm just curious from a more clinical perspective why some folks may trend towards some rather than others. Just a thought more than anything else.
There comments or questions from the group? You curious? Yeah. Here comes Joe. Make him run.
Okay, you mentioned that telephone wasn't an effective way to communicate. Did you get any feedback from your patients as to why that was? Because I know we've had to use that as a way to kind of reach out to some of these people, because otherwise they're sitting there in limbo, or at least they used to be, waiting for mental health intervention after they had initially seen a nurse practitioner or a family physician. So, we can't physically always see everybody within a timely fashion. So I just wondered if they had communicated why that was.
So initially, the pharmacy assessment tool was going to be administered by the pharmacist. And so a pharmacist is not a typical partner in your care with regard to MDD. And so there was some confusion about perhaps maybe what his role was when he was trying to call the patients at 2 weeks. So at that point, we developed an information sheet about the role of the pharmacist and how they can be valued. And still, people just wouldn't answer the phone. And so that was when we decided that we'd get the nurses, the NPs to call. And again, they didn't want to answer the phone. So we started to then book them in for appointments at 2 weeks, and they would show up. So there's something about, I don't know, about the phone, and maybe it's not considered to be as effective as a method of talking about depression.
Interesting. I think we have one more final comment. Bosa?
Hello. Thank you very much for the presentation. I'm actually going back to Catherine. And I was wondering what happened to her, because it appeared that, together with the adjunctive treatments and the medications, the PHQ-9 dropped significantly from 24 to 11. So when she stopped the antidepressants, did you follow up? What happened to her?
Yes. Sure. So, yeah, definitely we followed up. She came in for her appointments with regard to antidepressant follow-up anyways. And we discussed it, and that was when we really realized, and I've known her for a long time, that having nausea is an adverse side effect that would definitely impact her belief that the medication was working. So actually just saw her a couple days ago, and she's doing fantastic. So we were really pleased to be able to offer something to her that really spoke to her health beliefs and something that she was going to engage in.
Excellent. Thank you very much, folks. So as they receive their certificates, the Grand River Hospital Transition and Discharge, Trish, Nancy, Sherry, and Stephanie. And just, you know, it's something sort of stick in your mind, and when you think about the conversation and your question about the telephone, and we always make this assumption, right, that's going to work, and yet maybe that it's an assumption that sometimes we have to check out. I always find those things very curious and interesting.
First of all, I'd like to introduce our project team. We have Sherry Hempel-Pierce from the Grand River Hospital, Stephanie Robinson from Waterloo Wellington CMHA, and Trish Benoit, Waterloo Wellington System Coordinator. I'm Nancy Dickinson from the LHIN, Home and Community Care, which I will refer to as home care just for ease of discussion. So this is a profile of a typical patient that we were seeing prior to our project. Bob was discharged from the Grand River Hospital with a diagnosis of depression. He was referred to the home care program with mental health nursing and possibly with other referrals, but he couldn't remember. And for the mental health nurse, knowing that our service is meant to be time limited, it was important to know that he was at least on wait lists for some longer term supports. And this meant a lot of phone calls and investigations to find out what referrals had been made, appointment times, follow-ups, and so on. And also, we had no consistent method to monitor his depressive symptoms, especially during that 2-week period post-discharge. Enablers for our project were that our specific project was actually a smaller part of a larger system project for all Grand River Hospital mental health patients. And the major depression standard was identified as a priority by our local LHIN and the Mental Health and Addiction Program Council Network. There was a high level of support from all community partners and senior leadership. And the long-term commitment to the larger project suggested a higher level of sustainability. We also really benefited from Shauna's coaching and assistance at all points in our project. Some of the challenges were that the diagnostic tools actually changed the scope of the project. We discovered that sometimes through the mapping process, the right people weren't actually at the table. For example, the hospital had more of a need of the here 24/7 person rather than specifically a fact worker. The ideas vision started too large. It did include CMHA in a way that was not workable at that point, so we scaled back and focused on the home care component. And we learned that standardized tools and new work processes for both hospital and community take time to be adopted, and staff need orientation along the way. So the system opportunity was that there were no standardized hospital and community admission and discharge planning processes being followed. And this resulted in a very fragmented system for patients and their family, and information came to them from multiple service providers, adding to the confusion and lack of clarity. The future state we envisioned will include standardized processes to reduce duplication in testing, assessment, and service delivery. And it will emphasize increased communication between hospital, primary care, and community care. Our aim was that by March 2018, 90% of major depression patients admitted to Grand River Hospital, acute inpatient, will have a face-to-face visit with a provider. And this, we focused on one primary care provider, which was the Andrew Street Family Organization, CMHA, and home care within 7 days of discharge.
So our change ideas and implementation, The PHQ-9, as Nancy had mentioned, that came on a little bit later as we were working through with our project. So what our goal is that a PHQ-9 will be completed at admission at Grand River and also on discharge, and that information will be shared with the primary care and the Lynn HCC. And again, currently it's just with the Andrew Street that we're focusing on with the PHQ-9. We would also be then, the second PHQ-9 will be completed when the mental health nurses through home and community care will be seeing the patient post-discharge. So also clients diagnosed with MDD to be seen by the HCC or Andrew Street Health Team within 7 days of discharge. So notice of admission sheets are being sent to Andrew Street to the physicians to let them know that their patient has been admitted, and an invitation to care planning. Discharge instruction sheets will be sent to Andrew Street with the date of the first physician appointment. And the HCC appointment with appropriate clients will be booked within 5 days of discharge, and that's because of their mandate within the 5 days. Also, estimated discharge dates. Patients' discharge dates will be posted and will be actually on our MedWorks within Grand River Hospital, so that everybody is on board in regards to what target dates we're working towards. And then the next steps are also to share with community partners the standard length of stay that we would be looking at, and that also individual discharge plans would be shared with the HCC, Lynn, and then also with the family docs. This is a notice, an example of the notice for admission that we are sending to Andrew Street, and the clerical will send that in for us. This is the discharge instruction sheet that's more detailed so that the physicians, when they get this, because not always is the physician's final discharge report normally ready, so this gives them a starting point. So qualitative results in that we're going to be looking at is percentage of patients whose information is shared with primary care, number of patients who've had follow-up with Andrew Street post-discharge within 7 days, and also time from referral to first visit with the mental health nurse. And there was also a balancing measure in there in regards to when we were going through this process. The Lynn went from having paramed with their nurses, and then the Lynn had actually hired their own nurses, and so just capacity issues of trying to reach that 5 days. Number of completed PHQ-9s, and then the number of days to appointment at Andrew Street, and the number of days till inpatient or in-person visit with the Lynn nurse. So here is a run chart in regards to the notice of admission that was sent to Andrew Street. We did not do unfortunately, the number for 7 days for appointments, because for some reason that fell off the radar with the teams of making sure that part was actually completed. So you can see there was definitely at the beginning a struggle, and then we are on the road and trending in the right direction now. But there was definitely lots of PDS cycles that were going through there to try to figure out what was preventing to get these appointments booked. Qualitative results and impact. At Grand River, some of the feedback is that we felt the process would be easier to adopt if done for all patients, not just major depressive patients. Again, it's a 52-bed unit, very busy, so some of the work process was falling off because of that. Positive response to the addition of a standardized tool. And from the Lynn nurses, some of their feedback was because the major depressive was a smaller portion, and so again, working with a smaller group of folks. And then also the time between meetings created an opportunity for them to forget the PHQ-9, language barriers, and but they did feel that the PHQ-9 will continue to be used and thought it was appropriate. So improvements and steps moving on. The plan is for a community meeting to inform partners with Grand River Hospital the length of stay. Sharing estimated discharge dates will help to enable community partners to be prepared for client care when being discharged. And we're looking at doing that this March. Exploration of Here 24/7 to be present at GRH to allow client access to a wide range of mental health services. And going back to the telephone issue, having someone in purpose or in-house goes a long way to be able to make that contact with the client and also with the team. Explore avenues for collateral information sharing from the community to hospital, and align this with the conversation length of stay targets.
Thank you. As you collect your thoughts and read the last 3 points on the slide, comments, questions, panel? Ross?
So I may have misunderstood, but I thought you said that when the patients are leaving the hospital, you have appointments booked in the family health team. Can you talk a little bit more about the process of doing that and how reliable you think that's going to be?
Yeah, well, that was the challenge, is that so we had clerical doing that in combination with the team leads, and again the focus on folks with just the major depression. So, and we were focusing and started off with the Andrew Street Family Health Team and then wanting to expand. So what was happening is they had a spreadsheet to try to keep track of things. You know, the notice came, we received the information back. And then it trailed off where, yes, it dropped off, is that at discharge, they forgot to get the phone call to book that 7-day appointment. So, so through lots of conversations and that, what we've done is we actually have the spreadsheet that is there right behind the charge nurse station. And so they have tracking that for Andrew Street. Yes, they have sent the notification. Yes, they've received it. Yes, this is booked. So now they can see what is outstanding, and it's actually being brought to the team huddle in the morning for follow-up.
Yeah, I think that's very helpful detail, because that, especially when you're crossing organizational boundaries like that, it's quite challenging. But I think that's a critical piece. So you're gonna tie that in and make it happen.
Yeah, and the other challenge too is sometimes the discharges, you know, can all of a sudden just happen that day. And so then it's trying to get a hold of primary care. With Andrew Street right now, we have the backdoor number because we've got that relationship that we're working with. The next step for us is the Center for Family Medicine. Now they are already doing it on their own. They're checking through Clinical Connect every single day their patients that are being discharged from hospital or that have been, and they're reaching out to their folks and booking 6 days follow-up. So we will be working with them in the next step, but yes, it is going to be a challenge with primary, especially as we know, just booking your own family appointment, right, to try to get through to the doc. And that's why, again, encouraging the teams, knowing the estimated discharge date, doing that planning, is it doesn't have to be done last minute, right? And getting that done prior to.
Thanks.
Yeah,
one thing that stuck out to me for some of the people, communication to the community is hard. And it's funny that hospitals still kind of rely on faxes. And even I went to a medical legal talk recently and saying that everyone thinks that they can't use email, secure email, and that faxes are more safe, and they actually say there are more medical legal issues with faxes in the sense of going to the wrong number or going to the wrong place. And I wonder in small settings, I help out with the team in Timmins where I actually do most of the communication with the family doctors by email, and they have that one mail. And I wonder in some of the cases, especially where it's more smaller and you have a few community partners or one community partner you're working with, if there's an agreement like we both use a secure email, it's an easier way of keeping track of responses and people with notification. I know it's like an added thing in some ways, but I do find fax sometimes is a loss because you don't know if I went it through. Like the actual technical use of fax, sometimes I find is a barrier. Like I don't know, I have to wait for a response, and then sometimes I have to go, and then I find out the next day that, oh, I got rejected. And so I just wonder for some of the groups that are smaller, if you have these small partnerships, if that's something that could be considered.
It's something that we definitely need to work on and fully recognize, that is, and, and then even carry that over to connecting with patients too, right? Technology has come that way, so answering the phone, they're not, but will they get a text and receive that? Yes, absolutely. So looking at better ways of communicating between the two, for sure.
Thank you.
Yeah.
I was going to ask a quick question, and you probably mentioned it just from a sort of process and measurement perspective. So obviously you're catching the number of folks who are discharged and receive that face-to-face appointment at Andrew Street, but you're also, if I understand correctly, capturing the number who are, that's the appropriate referral for them, so they are accepted into programs following the referral, and also sort of once they receive that referral, is that having possibly a balancing problem down the road? So they get the referral appointment, but is that causing them to wait longer because you're now having more folks going for that initial referral? And is that something that you're looking at? Just by having that referral within 7 days, is that causing an issue later down the system where now they're having to wait longer because you have more people getting that?
Yeah, so I'm going to try to, and so that was part of our challenge, was because we knew that we were referring to multiple sources. So that's why we ended up taking CMHA off the table initially, because we didn't have the ability to kind of measure any of that, like if they were getting the referral. Because, and the piece that wasn't mentioned in here is we have really long wait lists in Waterloo Wellington. We have like over a year just to get connected to CMHA case management support. So that's very, very challenging for us right now. It's a huge challenge. So we focused on the home and community care because we have the ability to monitor if once they get referred to them, they have that 5-day target and we can measure it. But that's part of our next steps, is to work with CMHA. So the Here 24/7 worker would actually put the referral in for service, and in kind of tandem with the last question, we're actually building a electronic platform that allows our local CMHA to upload into EMRs, so into Clinical Connect. And so those referrals that have been sent in will actually be able to be seen by places like primary care, when the referral was received, if the person's connected to services or anything like that. So it's a longer term system project, but we are working on those pieces. I don't know if that answers it.
No, that's really helpful. The only other thought I was having too was I wonder if there's an opportunity, because it's such an important project, looking from an experience-based co-design perspective at that capturing and understanding that client experience from when they leave to when they get their referral and start, because that would be an interesting perspective, I think.
Yeah, and we absolutely have the capacity of doing that. It's kind of interesting. My role is to do those things. I'm kind of this neutral party that does that system work. So I have the ability, the project's fortunate to have somebody that can focus on those things that isn't attached to any one agency. So that is part of the planning.
It's a great project.
Excellent. Thank you so much. Thank you. Can we get your photos? So thank you to all the teams who presented this morning, our inspiration, motivation, and of course now we'll move to lunch where you can get some celebration. Oh, go get your photos. Go get your photos. Go get your photos. Go get your photos. Just as now we can all watch you get your photo. Just as this group does receive their photos, I just wanted to, I think Dr. Benassi has to leave us after lunch today, so I did just want to thank him for being here on the panel and for being one of our subject matter experts throughout the cohort as well, so thank you. So, and don't forget that a couple of teams this morning mentioned they brought copies of things with them, so if you want to seek them out, and we will talk at the end of the day about how we're going to make sure you continue to have access to all of these tools and resources. But we will break for lunch. We'll come back at 1:45 because we will start our live cast again at that point, so enjoy your cupcakes, and we'll see you back at 1:45.